Hello. Hello.
For this year. The new president of Society for new president.
Hello.
For this year. Good evening. Good evening. Good evening and welcome to one and all present here. The Society of Vaginal Surgeons of India, TN chapter, and Varam by MGM proudly welcome the dignitaries, doctors, and our dear colleagues to witness the installation ceremony of the new president of SOVC. This prestigious event will be followed by a CME program, which will be instrumental in understanding the important aspect of women's health. I'm sure we will all agree that this is a very proud and an honorable moment to all the fraternities at Varam and MGM Healthcare. I now kindly request Dr. Nivedita Bharati, Senior Consultant, Obstetrics and Gynecology at Varam by MGM to take the event forward. Over to you, ma'am.
A warm good afternoon to one and all gathered here. It's really a happy moment to see everybody face to face after almost a year and a half of virtual gatherings. Sorry? This mic. Okay. A warm good afternoon to one and all gathered here. And it's really a happy moment to see everybody face to face after almost a year and a half of virtual gatherings. And to start the program, let me invite the dignitaries to the dais. May I request Dr. P.M. Gopinath, who is the founder secretary of the Tamil Nadu chapter of SOVC, that is the Society of Vaginal Surgeons of India, and who is the current president of the same society, to come on to the dais, please. So next, may I request Dr. A. Jayashree Gajaraj, the Senior Consultant at MGM Healthcare, who is the incoming President of the Tamil Nadu chapter of SOVC, and Dr. Nirmala Jaishankar, Senior Obstetrician and Gynecologist, who is going to be taking over as the Vice President of the Society. And may I also request Dr. Shrikala Prasad, who is the current Secretary of the TN chapter of SOVC. To start the installation ceremony of the new office bearers, before that, I would like our CEO of MGM Healthcare, Mr. Harish Manian, to hand over the bouquet to our current president, Dr. P.M. Gopinath. So may I also request you to hand over the bouquet to Dr. Jayashree Gajaraj, who is the incoming president of the society. Now may I request our COO of MGM Healthcare, Mr. Rajarajan, to hand over the bouquet to Dr. Nirmala Jaishankar, who is taking over as the vice president of the society. May I request Dr. Lakshmi Aswathaman, who is the head of the Department of OBGYN at MGM Healthcare, to present the bouquet to Dr. Shrikala Prasad, who is the current secretary. As we start the installation ceremony of the new office bearers, may I request Dr. P.M. Gopinath, who is the founder secretary of the Tamil Nadu chapter of the Society of Vaginal Surgeons of India and the current president, to formally hand over the office to the incoming president, Dr. R.K. Jayashree Gajaraj, and to give the introductory address.
To most of you who are not familiar with SOVC, this is the Society for Vaginal Surgeons of India, and it all started with an initiative. Can you move on the slide, please? Next slide, please. The society was formed with under the patronship of Dr. Rustam Sonawala from Mumbai. National convener was Dr. P.C. Mahapatra. President was Dr. Shri Sheth. And Secretary General was Dr. Harapatnaik. So both Harapatnaik and P.C. Mahapatra approached us to start a Tamil Nadu chapter. And based on that, we have just started the chapter. Next slide, please. So we have started the Tamil Nadu chapter, and patron is Dr. Kurian Joseph, and I'm the president, and vice president is Dr. Jayashri Gajaran, and secretary is Dr. Srikala Prasad, and joint secretary is Dr. Shanti, treasurer is Dr. A. Tamil Selvi, and executive committee members are Dr. Meena Umachanda, K. S. Chitra, Dr. A. Chakravarti, Dr. Ramani Devi, Dr. G. T. Selvan, Dr. K. Saraswati, Dr. Lily Varghese, Dr. S. S. Subba, Dr. Madhubala, and Dr. Ramya Jera. All of them are from different parts of the Tamil Nadu, and they have been representing, and then the society was formed. Next slide. So when we started it, we started with that initial inaugural ceremony on 27th of September. So we had a very good interactive webinar where Dr. Meera Raghavan spoke on the relevant anatomy. Dr. Srikala Prasad presented on preventive measures of wall prolapse, and various aspects has been discussed in details about the theme of this conference was wall prolapse. And that day we have decided we will have a monthly meeting every month. Next slide. So the next month meeting, it was a tips on vaginal hysterectomy on non-descent uterus was conducted by Dr. Meena Umachandar and Dr. Usha Rani. They had an interaction for about an hour, and which they discussed on various intricate things about practical aspects of vaginal hysterectomy. Next slide. So then after that, we had a session on pelvic organ prolapse on November. So this was headed by Dr. Rajamaheshwari and Divya Ebenezer from CMC Vellore, and Lily Varghese, and Dr. Tamil Selvi, Sita Lakshmi, Lalita Devdasan, and Meena Mahalingam. All of them contributed on various aspects of surgical techniques and current concept of pelvic organ prolapse. Next slide. And then we had another interesting session where Dr. Ajay Rana from Australia has just took part. And then we had, this was the program on that particular month. We had a very interesting session. Next slide. And this is again another very interesting session, teaching vaginal surgery the new way. Dr. Ajay Rana just brought out something like exoscope, something like a laparoscope. He brought an instrument, and with that, he was just showing a much easier way of teaching vaginal surgery. Next slide. So, and then following that, myself and Dr. Kurian Joseph, we had a very interesting session on the development of various aspects of vaginal surgery, right from Dr. Kurian's father's time until now. What are all the different ways, different energy sources, the merits and demerits of all those things we discussed. Next slide. So here, under the guidance of Jayashri and Nivedita, we arranged an international faculty, Mr. C.L. Lee, and he just gave a talk on vaginal hysterectomy with bilateral salpingectomy, which was a lost art. It was really interesting, and the way in which they are just doing it as simple as possible was really enlightening to most of the audience. Next slide. And this was again another international webinar on uterine preservation. Can you just want uterine preservation while treating the uterovaginal prolapse? It was done in April. Dr. Rajiv Verma, who is the medical director of the Safe Obstetric System and a consultant urogynecologist from Essex Newfield Hospital, and he gave a talk, and then he showed various demonstrations on all the procedures. Next slide. He is specializing on intravaginal sling. Then on May, we had Dr. Vasudev Panikar, and he has brought out all his innovations in vaginal surgery. And it was again a very interesting session. He showed all his new instruments, what he has devised, and he has been using it. Next slide. And then we had this month, it was a Foxy, Everfog, and then Oxy all put together. It was a session on urogynecology, present, future, and was for the gynecologists. It was again a very interesting international session. This was just taken at that monthly activity. Next slide, please. Dr. Sashireka, can you please mute? Yep. Yes. Next slide. And here in this July, we had prevention of urological injuries in obstetric practice done by Dr. Srikala Prasad with the chairpersons Ajit Vas and Dr. J.B. Sharma. It was again an eye opener and it was a very useful session. Next slide. And here on August, we had vaginal mesh for prolapse. Is it a reality or a myth? So it was discussed in detail by none other than Dr. V.P. Piley, and all of us know about his pioneering vaginal surgery. Next slide. In September, we had something like a debate on conventional vaginal hysterectomies with the clamps and sutures, what we do, against the newer Ramakrishna Purohit spoke on newer vaginal, the energy sources for vaginal hysterectomies using his novel bipolar clamps and other things. So it was very interesting, and it was really a lot of tips was thrown in that particular webinar. Next slide. So here in October, we had an interesting session, pros and cons of the vaginal approach for urological injuries was dealt by Dr. Muthu Veeramani, who is a very eminent neurosurgeon. And the Dr. Patta Radhakrishna gave a talk on limitations and advantages of vaginal approach for lower GIT injuries. Next slide. So with that, we have come today for this program. So we have conducted about 13 webinars, including about 5 international speakers. And it was really a delight to head the society from Tamil Nadu. And I wish Dr. Jayashree to take over and then conduct many more such interesting programs. And I wish you all the best, Jayashree.
Sir, for giving us an idea of what the society is all about and briefing us about the activities in the past year. May I request the incoming president, Dr. Arka Jayashree Gajaraj, to address the gathering.
Good afternoon, everyone. I thank all of you who have joined installations today, both in the hall as well as virtually. It is indeed a very proud moment for me to take over as president of the Tamil Nadu chapter of the Society of Vaginal Surgeons of India, and especially a very proud moment to be taking over from Dr. Gopinath. Because Gopi, I'm sorry, that's the only way I can call him. He has been in several ways a mentor. He has literally guided me through my MD thesis, through all the little things that one needs to do as a postgraduate, working in IOG, and especially what not to do if you want to pass your exam. So he has taught me a lot. but he's a very, very close friend, and our friendship goes back several years. So that is why this particular moment is even more special for me. Thank you very much, Gopi. Almost a year ago, he called me and said, we are forming this association and I'd like you to join me as vice president. Yes, I was very, very thrilled because vaginal surgery is one of my passions. And I hadn't really heard about this society earlier, but it was very, very happy. I was very, very happy because a dedicated society for vaginal surgery was something I'm sure we can do a lot of work in this. And this past year has shown, I'm told that Tamil Nadu chapter was the only chapter of SOVC who has had a program every month last year. So hats off to Dr. Gopinath and Dr. Srikala, who have consistently brought out quality programs every month. Thank you very much, which means the bar has been set very high for the incoming team. And I'm very, very happy that Dr. Srikala is going to stay with us because we will continue to get her help and guidance. And without doubt, a lot of guidance from Dr. Kurian Joseph and from Dr. Gopinath. So we can only go upwards from here. I'm very confident to have Dr. Nirmala Jaishankar with me, again, a very close friend of several years. So I think we will do a good job. I will promise to do a good job, Gopi. Especially last year, everything was online. So I said, okay, why not have a physical, meet today and at least meet, if nothing else. And while we meet and have a cup of coffee, I thought I would take over the presidentship from Dr. Gopinath. So thank you very much. Maybe in the year to come, we can include the number of physical meetings, increase the number of physical meetings. We could do more video sessions, more surgery workshops, etc. And the main aim, I think, should be to ensure that vaginal surgery does not become a lost art. Because even in my training days, I really honestly had not seen a non-distant vaginal hysterectomy. So it was much later when I started practicing, when this thing, people used to talk about this, but I have never done one myself. And here I must acknowledge the fact that Dr. Nirmala Jaishankar, Dr. Geeta Haripriya and I used to work together a lot on Sundays at Apollo Hospital. And that was when we used to do a lot of things together. So working together meant a lot. And again, I cannot but not accept or acknowledge the encouragement given to me by Dr. Tenmuri, who used to work with me. She was again one of those very silent workers, very keen on surgery. And I think that's the way we started way back in the 90s, and I'm happy where we are today. And I'm happy I'm able to do a lot with my current team, with Dr. Nivedita Bharti, who is with me, again, somebody who is very committed to vaginal surgery. So let us now make a commitment to bring more youngsters into this society so that we can ensure that definitely we hand the baton on from one generation to another. And those who do vaginal surgery know that it's such a pleasure to do it. I think there's nothing more to say about it. Yesterday, I got a call from Dr. Jayashree Srinivasan, who said, I'm in, please take me in. So she's here today with us. Thank you, Jayashree, for joining us. And it's indeed my pleasure to welcome Dr. Nirmala Jaishankar. You will be introducing her, or Gopi. Dr. Gopinath will welcome her. So thank you very much once again, Dr. Gopinath and Dr. Srikala. Thank you.
Thank you, ma'am. Now may I request Dr. Srikala Prasad present a shawl to Dr. Nirmala Jaishankar and welcome her as the Vice President of the Tamil Nadu chapter of SOVC. So may I request Dr. Nirmala Jaishankar, the incoming Vice President, to say a few words.
Good afternoon, and thanks everyone for coming for this installation ceremony. Whenever me and Dr. Jayashree go for any conferences, they used to mistake and they used to call me Jayashree and they call Jayashree Nirmala. So our association goes a long way. And Gopi and Shrikala, it's like all friends together. And I can only remember the slogan, "Together we win." And you must all be wondering why another society for vaginal surgery. So vaginal surgery is actually a truly minimally invasive surgery, if you really look at it. For a very long time, the vaginal route was the minimally invasive route. And it is a very route which can be practiced with very minimal instruments, and it can be practiced anywhere with low cost. We are not denying that endoscopy is an excellent surgery, but when we dwell into the endoscopic surgery, we should not forget the art of the vaginal surgery. With that in mind, the society was started, and Dr. Gopinath and Dr. Kurian and many more vaginal surgeons were there when we were all were, Gopi was our co-PG, but then Gopinath was so fast in vaginal surgery, if you blink a moment, the uterus would have been out. So such was his skill in vaginal surgery. So it is very nice to watch a great vaginal surgeon do a vaginal surgery. It is like a performing art. You really enjoy the tissue plane, and it is a surgery which gives you immense pleasure and satisfaction to the patient. And if you do the surgery like a non-distant vaginal hysterectomy, then the patient can walk out of the hospital the next day. That is the advantage of the vaginal surgery. No holes, no endoscopic cameras, and actually I need to add one more word, that the laparoscopy was introduced to make a complicated abdominal hysterectomy an easy vaginal hysterectomy. So I think all the surgeries should go hand in hand, and we should be kind of well-versed in performing every kind of surgery, because for every patient, a particular surgery will be advantageous. So with this in mind, the Vaginal Surgery Society has been started. Gopi and Dr. Shrikala has set the bar really high. Every month on month, they used to do these wonderful conferences. I wonder, because we were like, there were so many webinars, but the SOFC webinar was one where we never missed it, because it brought out a lot of little points of practical importance to us. So thank you, Gopi, for setting the thing. And I'm sure with Jayashree, she's a taskmaster. So, all of us have to work very hard with Jayashree and carry the society's work forward. And we plan to conduct a lot of probably live surgeries this year. Now that the corona is going to be out of the way, let's see how best we can do it. And I would like to once again thank everyone, including MGM, for providing this beautiful, the auditorium for us and everyone. And we would like to invite a lot more members, especially Jayashree Srinivasan was an assistant when I was a PG, and she can operate with both the hands. She was a fantastic vaginal surgeon. So I'm so happy that she's here to kind of bless us for the installation ceremony. Thank you so much.
So thank you, ma'am. Once again, on behalf of everybody who's gathered here, I congratulate the incoming president and the vice president, and we are looking forward to a fruitful year ahead, ma'am. Now we move on to the CME program of this evening. After that. As we move on to the CME program, as we all understand, laparoscopic hysterectomy is described as the technology, abdominal hysterectomy as a surgery, and the vaginal hysterectomy or a vaginal surgery is an art. So to prevent that from becoming a lost art, we have to be very strong in our basics. So let us start with our CME with a basis. And we have Dr. Thamizselvi, who is going to join us virtually, and she's going to talk on the clinical anatomy of the pelvic floor. Over to Dr. Thamizselvi. So
Thank you.
she is currently the urogynecologist and the pelvic floor surgeon attached to Madras Medical Mission, Mangai Women's Health Exclusive, and SMF Chennai. And she is very much interested in teaching, and she has been the organizer for the Part 3 MRCOG course programs. And over to you, Dr. Tamiselvi.
Thank you, Nivedita, for the introduction. At the outset, I would like to congratulate the incoming team, President Dr. Jayashree Gajraj, Vice President Dr. Nirmala Jaishankar, and Secretary Dr. Srikala Prasad. Congratulations to all three of you. Now, moving over to the clinical anatomy of the pelvic floor, which forms the basis of the vaginal surgery. And I would like to thank Dr. Jayashree Gajraj for giving me this opportunity, because this is a very important component of vaginal surgical training. When we look at pelvic anatomy, as far as surgery success is concerned, in fact, for any surgery success, a thorough knowledge of the anatomy with a good surgical exposure dictates the success of any surgery, and that is very true in vaginal surgery. And traditionally, pelvic anatomy, when we think of pelvic anatomy and in relation to imaging, so my talk is going to be a prelude to the subsequent talk by Dr. Rupa, who is going to be talking on imaging of the pelvic anatomy. So when we think of pelvic anatomy and imaging, traditionally we look at pelvic organs, and in fact, pelvic organ has become as synonymous as imaging, because no one is even actually, at least the younger generation, is not even putting their fingers to assess the size of the uterus or the ovary. They just put the probe inside and check the size of the uterus and the ovary. So ultrasound has become a main modality, and imaging of pelvis means imaging the pelvic organs. But imaging of the pelvis is just not the pelvic organ. We are just not looking at the pathological anatomy. We are not looking for cysts. We are not looking for fibroids alone. There is more to pelvic anatomy when it comes to vaginal surgery. So apart from the pelvic organs, what are the things we need to understand when we are talking of vaginal surgery? We know there are bony landmarks, which we need to be aware, especially the ligamentous structures, which are going to be important components on surface landmarks when we are operating in a very small area. And by palpation, we identify the bony landmarks and the ligaments. So it is important to know the bony landmarks as well as the ligamentous structures, the sacrotuberous ligament, the ischial spine, the sacrospinous ligament, the obturator fascia. All these needs to be trained by the finger to know where exactly these are. Now, apart from the bony landmark, what other thing we need to be aware of? Okay. Apart from the bony landmark, what we need to know is the fascia. The most important component of pelvic structural integrity is the facial structures. When it comes to fascia, we need to understand that there is a facial support, which is the condensation of which forms the ligament. So the fascia and the ligaments are continuous structures. They are not actually synonymous with just ligamentous support. Now, when we are looking at facial structures, the anterior vaginal fascia or the pubovaginal fascia extending from the ischial spine onto the pubis is a facial layer.
Dr. Tamiselvi, can you please share your screen?
It's shared, maybe. It is on screen sharing.
Can you please stop and start again?
Okay.
Thank you.
Do you want me to go back on the slide or?
Yeah, now it's visible.
Now it's visible? Okay.
Yeah, go on the slide share.
Okay, fine.
Yeah.
Is it okay now?
Yeah, thank you.
Okay, fine. Now, when we are looking at facial structure, we are looking at pubocervical fascia anteriorly and the rectovaginal fascia posteriorly. And what we need to understand is these facial elements are transverse elements which are extending on either side to support the pelvic organs as a hammock. So their attachment is along the white line from the ischial spine onto the pubic bone. So the white line is also known as the arcus tendinous fascia pelvis, which you might remember from our anatomical days. Now, when this facial support fails, either the anterior or posterior vaginal support fails, if you look at this image, you will understand that things will start to sag down. So that is one of the important reasons why we need to understand that anatomy. Only when we know what these facial elements are, we can actually correct those facial elements to obtain a better idea of how to do the vaginal correction. Now, these facial elements undergo condensations, and these are the ligamentous supports. So condensations can be either pubourethral ligaments, can be uterosacral ligaments, and these ligaments actually move the pelvic organs backwards and forwards depending on our position, depending on the function of the pelvic organ which we are dealing with. So once we finish the fascia, the bone, and the ligaments, what is left behind in anatomy is the muscular component. In the past, the perineal muscular component has not been given its due diligence because it was just a part of the pelvis and it was sitting at the lower end of the body, and not much dissection was done even during our anatomical days to understand how exactly the things move from backwards upwards. So when you actually look at the anatomy, you know, you're looking at the skin and the muscular layer, skin and the fatty layer, and also then you move on to different facial and muscular components. Before we move on to the different muscular and facial components, let's look at the imaging modalities, what we are aware of. We are aware of X-ray, which is predominantly used to look at body structures. Then came the ultrasound, looking at the, in relation to pelvis, the pelvic organs. Then the computerized tomography, CT scan, then MRI, PET scan. Each of these provided us with different knowledge of different components, looking at pathology, looking at functional problems, looking at malignancy, looking at other recurrences, so back and forth. So all these imaging modalities did provide us with some pathological diagnosis. What, as a vaginal surgeon, what is it we are looking at? We are looking at surface anatomy. Surface anatomy is the anatomy of the external genitalia, which is learned actually by just looking at the patient a day in and day out. And then we are looking at the muscular and the facial supports. When we go from below upwards, the muscular, the facial support, which is underneath the fatty layer, is the membranous collis fascia, which is a continuation of the abdominal fascia, followed by the superficial perineal muscles, the ischiospongiosus, bulbospongiosus, superficial transverse perineum, and the external anal sphincter. We need to image these. We need to image these to find out exactly what is the function of these muscular fibers, which are helpful in maintaining the continence of the anus. So we need to know how exactly this is working. And when we move slightly inwards, we go on to the deep perineal pouch. When you're looking at the deep perineal pouch, you're looking at the urogenital diaphragm, with the deep transverse perineal muscle. The function of this, which we haven't yet alluded to, is probably we will learn in the next few years. I have a theory that the deep transverse perineal membrane and the perineal muscles do contribute to a significant extent in the urethral continence. Let's see what history tells us, with what the future tells us. Now, when we go inwards from below, we look at the roof of the perineum, which is the levator ani, or the pelvic floor muscle, which is basically the most important component as far as the female pelvis is concerned, because it is holding on to all the abdominal contents as well as the pelvic contents. So it is preventing everything from sagging downwards. So the levator ani component, with the pubococcyges, ileococcyges, and the ischiococcygis, forms an important element of the pelvis, with the pelvic organs resting over it. When we remove the pelvic organs, then we know the roof of the perineum, or the diaphragm of the pelvis, actually is not just a smooth muscular layer. We can look at the white line, we can look at the facial attachments. We know these are condensations to form ligaments. So what do we want to know? We want to know how these things look inside the body as a result of imaging. We want to know how exactly these structures look like. We know how the uterus and ovary looks like on ultrasound. What we want to know is, where are these attachments? Why do we want to know these attachments? Because when these attachments fail, these organs can fail. So because it is a structural component, when these organs fail, when the structure fails, the function of these organs also fail. So the structure and anatomy becomes more important. Why? If you look at the perineal muscle, if the perineal muscles, or the pelvic floor muscles, I should be saying, not the perineal muscle, the pelvic floor muscles, if they are actually supporting the pelvic organs, remember these are the pelvic floor muscles and they are supporting the pelvic organs. And these are the fascia which are in addition providing the support. If the water gets drained, that is the pelvic floor musculature becomes actually defective either due to aging or due to childbirth, or it gets drained. Then what happens? The whole support hinges on the fascia, and the fascia might not be able to hold the support, and then it can tear and give rise to prolapse and other structural problems. So this is very important for us to know, to plan surgery whether, and also more importantly, to tell the patient the recurrence risk. In a patient who has got a very defective pelvic floor muscle, it might be easier for us to say your recurrence risk is not going to be 10 or 11%, your recurrence risk is going to be 20%. So the patient will also understand that she should avoid other contributing factors in recurrence, such as avoiding constipation, should not be putting on weight, should regularly exercise the pelvic floor musculature. Counseling becomes more effective, and the surgical expertise and the surgical success of a surgery also becomes better. So if you look at imaging, now it has also grown exponentially in the last few years. Now, instead of just the 2D ultrasound, we are getting 3D ultrasound where we can look at the pelvic organs in all dimensions. We are also able to look at the pelvic floor in all dimensions. We are able to look at the musculature of the pelvic floor. And we look at the musculature of the pelvic floor. What we are looking at is the levator ana muscle complex predominantly. And if you look at this complex, when it is actually intact, the pelvic organs will stay intact on the top. When it becomes defective, you can imagine when it starts to sag down, everything will start to sag down. Remember the ship picture which I showed you. Now, pelvic floor dysfunction is not just about prolapse. There are other organs inside the pelvic floor. We have the bladder, we have the rectum. So the patients can present with urinary incontinence, can present with anal dysfunction. When it comes to urinary incontinence, it's a structural problem as well as a functional problem. So how can imaging help us? Imaging can help us because by showing when the patient has got a Valsalva maneuver, is there a bladder neck mobility? Is there a funneling of the proximal urethra? Then I will know whether this patient has got a stress urinary incontinence, whether the patient's sphincter mechanism is at fault. And by looking at the detrusor muscle thickness, I might be able to understand what is happening to the musculature, whether the overactive bladder is causing thickening of the musculature because the detrusor muscle is constantly contracting. So imaging does play a role. So if imaging becomes the norm, then invasive testing such as urodynamics can be avoided if we are able to get all this information through imaging process. So I'm waiting to hear from Rupa what best we can do in this aspect. When we look at anal dysfunction, the most important component is the external anal sphincter and the internal anal sphincter. A patient who presents with fecal incontinence or anal incontinence does not necessarily should have a sphincter problem. It could be a functional problem, and imaging becomes very important to identify whether the external anal sphincter is intact, whether the internal anal sphincter is intact. If it is defective, how to repair it, where is it defective, how to repair it best, and what prognosis can we give the patient. So in all aspects, the imaging and anatomy seem to go in hand when it comes to vaginal surgery. But pelvic floor problems are just not static problems. They are functional problems because the patient can be absolutely fine if she's just walking, sitting, standing, and doing nothing. But if the patient starts to exercise, you can have a problem. If the patient starts to cough or laugh, she can have a problem. Her symptoms can get worse by the end of the day because she has been walking around for a long time and she's been standing. So what we want to know is what happens to the pelvic floor when the patient is actually moving around. What happens to all these ligamentous structures? Do they pull the uterus backwards? Do they pull the bladder mid-urethra forwards? Do they pull the bladder neck forwards? What is happening when this patient has got a functional problem? So dynamic imaging will play a major role to find out what exactly is going on. So when it comes to dynamic imaging, we want to know what these structural elements are functioning. How far is the uterus moving? How far is the retroverted or an anteverted uterus is moving backwards? This will also play a major role post-surgery to identify what is happening. Is the vaginal axis corrected? Is the vaginal axis in the right angle so that we know whether there will be a recurrence of the cystocele or a recurrence of a rectocele? And in this aspect, MRI has played a major role, and this is something which is coming up new. And I will leave to Rupa to explain all these aspects of it. So we are looking at areas where we have imaginary lines, and we actually identify the pubococcygeal ligament-like structures from the pubic to the coccyx, and see for the descent with the patient, ask with the patient doing a Valsalva maneuver like a cough or a straining, and seeing how far it comes down. And this will play a major role in actually identifying the success of the surgery as well, and explaining to the patient how exactly to maintain her organs above the pelvic floor by doing proper pelvic floor exercises. So in conclusion, the anatomical principles in imaging should be able to look at not only the skin and the fatty layer can be looked through the eye, the surface anatomy, but when it comes to muscular structures and facial structures, by looking at the muscular structures, because the fascia is embedded within the muscular structures, we should be able to identify what is defective, where is it defective, and how best we can repair it, whether new surgeries are needed to actually correct these problems, and moving on to actually counseling the patient as to what their recurrence risk and how best their success can be. So ultrasound, CT scan, and MRI are going to help us, and I'm sure Dr. Rupa is going to tell us how best we can image all these structures and how best we can actually guide our management as well as guide the patient. Thank you, everyone, and thanks for the opportunity.
So thank you, Dr. Tamilselvi, for the clear and descriptive presentation as ever. And I'll request you to stay online for the questions to be answered after the presentation. Now may I request Dr. Rupa Ranganathan, I think she's joined us online, who's going to talk to us virtually from Coimbatore. And she's going to talk to us about the role of imaging in the management of pelvic floor dysfunction. Over to you, Dr. Rupa.
Is my screen visible?
Yeah, you're visible.
Okay. Good evening, everyone. Thank you, Society of Vaginal Surgeons of India, Tamil Nadu chapter, and especially Dr. Jayashree for inviting me for this talk on among great surgeons. Today, I'll be talking on how can we help in the management of pelvic floor dysfunction. So as we all know, it is one of the commonest, but it is very less addressed gynecological conditions. The literature says about 50% of postmenopausal women suffer from some form of pelvic floor dysfunction. And as we all know, for decades, we have been assessing and addressing the problem based on clinical examinations. And in the recent years, imaging has played a complementary role to the clinical examination of these pelvic floor dysfunction to address the problem in a much better way and also to optimize the surgical planning in these group of patients. So in the next 30 minutes, I'll be talking on etiology and clinical presentation a little bit, the imaging anatomy of the pelvic floor. Dr. Tamilselvi had excellently outlined the imaging anatomy and the comparison with the ship of with the pelvis support and the imaging modalities that are available for pelvic floor dysfunctions, the advantages and limitations of each one of them, and what do we really see on imaging. And finally, I will also be touching upon the guidelines, the consensus statement, which came up this year along with the radiologist, the urogynecologist, and the urologist in deciding on what is appropriate in imaging based on each clinical scenario. And finally, a little bit on the functional pelvic disorders too. Moving on to the topic first, the etiology and clinical presentation. We all know that a pelvic floor dysfunction occurs because of the abnormal descent of pelvic organ through the hiatus, secondary to weakened or ineffective both active and passive supporting structures. And this descent, widening of the pelvic floor can happen even during rest or during the evacuation. The etiologies are so many: multiparity, advanced age, pregnancy, obesity, menopause, even connective tissue disorders and smoking, a chronic obstructive pulmonary disease, or any disorder which constantly increases the intra-abdominal pressure. By and large, it's more common in a multiparous and it is much more common in the females. The clinical presentation can be just a varying degrees of pelvic organ prolapse, or can be even due to organ-specific symptoms from each compartment, like urinary incontinence, an incomplete emptying, and a sort of a pelvic pain or pressure because of the organs dragging down because of the weakened ligamentous and the fascial support, or can be a defecatory disorder from the posterior compartment. As I mentioned previously, it's been for several years have been the management, the diagnosis is based on the clinical evaluation. A good clinical examination is even now is as good as imaging. And the role of imaging in the evaluation of pelvic floor dysfunction is in select situations wherein there is a discrepancy between the patient complaint and the clinical examination. And when the clinical examination could not be performed completely because the patient is not cooperative, because the patient has got a lot of pain, and so on. And we all know that there are dedicated surgeries for pelvic floor dysfunction, and hence any inaccurate assessment will result in suboptimal choice of treatment, which can lead to potential recurrence. I'm sorry. Moving on to the imaging anatomy, the pelvis is divided into three compartments: the anterior, middle, and posterior. And the anterior compartment is comprised of bladder and the urethra, and the middle compartment is basically the gynecological organs, the uterus, cervix, and the vagina. And the posterior compartment is mainly the rectum and the anal canal. As we all know, the pelvic support is a complex interaction among bones, muscles, ligaments, and organs, which Dr. Tamil Selvi had beautifully said. The ligaments, muscles, and fascia, they combine to form a musculoelastic system. There are many structures in the pelvis which do not have an inherent shape, like urethra, vagina, and rectum. And these supporting structures not only support, but give them a form or a structure to these organs. And the fascia strengthen and support the organs, and the ligaments suspends the organs and act as anchoring points for the muscles. And the muscles forces stretch the organs, contributing the shape, form, and strength of these organs. And these supporting structures are formed in three layers from superior to inferior. Dr. Tamil Selvi has explained from the perineum, skin, subcutaneous tissue, and from below. I'm explaining it from superior to inferior. They are in multiple layers: the endopelvic fascia, the pelvic diaphragm, and the urogenital diaphragm. I'm not going into much of these pictures because she has already demonstrated. Endopelvic fascia is the most superficial structure, and the anterior compartment has these fascia extend from the pubis to the cervix, which is called the pubocervical fascia. And each of these compartments, the endopelvic fascia, also condenses to form ligaments. So these are some of the important ligaments, and few of them can be very well visualized on MRI. For example, the periurethral, paraurethral, and pubourethral ligaments, which are important ligaments for maintaining the urinary continence, can be very well appreciated on MR, and its damage also can be very well demonstrated, which I'll show in the pictures later. In the middle compartment, we have parametrium, the cardinal, and the uterosacral ligaments. And in the posterior compartment, we have the fibromuscular structure, the very important supporting structure of the pelvic floor, the perineal body, and the rectovaginal fascia. Among all these, there are only few that we can appreciate. We won't be able to appreciate the pubocervical fascia and the rectovaginal fascia directly on MR, and the damage is as concluded by the descent or the deviation of the organ. However, we can see a couple of ligaments like periurethral, paraurethral, pubourethral, uterosacral ligaments, and the perineal body. So this MRI in the axial plane, the T2 sequence, is actually showing all these periurethral, paraurethral ligaments. And this is the puborectalis muscle, which I'll be talking a little later. So this is the uterosacral ligaments, which can be very well appreciated on MR. And this is the cardinal ligament, or the space of the parametrium. And this is the round ligament, which is again very well demonstrated, a common site of endometriosis, common site for getting the tumor infiltration, which is a ligament which is important to maintain the antiflexion of the uterus. The next layer is the pelvic diaphragm, which lies deep to the endopelvic fascia, and it comprises of muscles. The two important muscles are the ischiococcygis and the levator ani. Levator ani have three components. There are three components of levator ani, which is iliococcygis, pubococcygis, and puborectalis. And contraction of these muscles are very important to maintain the pelvic tone. And the iliococcygis posteriorly condenses to form the levator plate. And this is a very, very important landmark that we see on MR. Its orientation tells us whether it is it has to be on parallel to the PCL line. And if we don't see, and if it lies perpendicular, we know that there is a very important contribution for the pelvic floor descent. And the puborectalis muscle, which sort of forms a U-sling around the urethra, vagina, and the rectum. And this also elevates the bladder neck against the pubis and is contributing for the urinary incontinence and also for the anorectal, the angle. The next, so this is a picture which demonstrates the puborectalis muscle. This is the MRI, and the same picture can actually be depicted very well on a 3D ultrasound. As you can see, these bright lines are the one which represents the puborectalis muscle on a 3D ultrasound, and which is seen as a dark line on MR. The last layer of the pelvic supporting structure is the urogenital diaphragm. This term is sort of obsolete, and it's now we use the term called the perineal membrane. This is inferior to the pelvic diaphragm, and the urogenital diaphragm actually will not cover the posterior compartment, and it covers only the anterior and the middle compartment, and it comprises of connective tissue and the deep transverse perineal muscles which are rising from the ischial ramus. So this is again an MRI which shows a puborectalis muscle, and this little hypointense dark structure which is seen between the vagina, which is distended by gel, and the rectum, anal canal, is the perineal body. And this is the ureter, vagina, and the anal canal. And this is the place of the urogenital diaphragm or the perineal membrane. And you can see that's the area of perineal membrane, again the puborectalis muscle, and that's little lines or the transverse perineal muscle. And the external anal sphincter, this is the anal canal, and this is the muscle which we always look at if it is damaged or if it is replaced by fibrosis, which is an important contributing for the defecatory problems. Moving on to the imaging modalities. Why do we need imaging at all? There are enough literature to tell us that a patient who presents with stress incontinence alone or with the prolapse have a significant number or significant proportion of them also have obstructed defecation, and imaging can lead to change in the surgical strategy and requires a multidisciplinary team. Even a proctologist have to be involved in a patient who presents with only a urinary incontinence in almost 67% of cases, and clinical evaluation can underestimate a significant proportion of patients who present with pelvic floor dysfunction. And you need to have the aim of surgical approach to understand the problem completely so that we prevent future relapse or exacerbations and do one corrective surgery for the patient. The various imaging modalities that are available are fluoroscopic defecography or cystocolpoproctography, transperineal ultrasound or the translabial ultrasound, which is the one which is very commonly used, and fluoroscopic voiding cystourethropy, MR defecography, dynamic pelvic MR, and pelvic MRI with or without contrast, and CT pelvis. Among that, the most commonly used ones are the fluoroscopic defecography, or the cystocolpoproctography, which means we image not just the defecatory anal canal and the rectum, but we get a complete picture. We instill contrast within the bladder, within the vagina. It's a very tedious procedure that's been done. And transperineal or the translabial ultrasound and MR defecography or the dynamic MR. The advantage and disadvantage of each one of them. The fluoroscopic defecography is a simple and rapidly done procedure. How the main advantage is being claimed for fluoroscopic defecography is it mimics the physiological position. So the patient actually, we can see what exactly the patient is going through by giving a contrast within the rectum and asking her to defecate. So it also gives us both qualitative and quantitative assessment. But there are a lot of disadvantages, and more and more MR is being used for the evaluation of pelvic floor dysfunction, where even a dynamic MR defecography can be performed. We perform now less and less of fluoroscopic defecography, and the last fluoroscopic defecography I had performed is during my training period. So that the main disadvantage is having an ionizing radiation because it's done under fluoroscopy. X-rays are involved, and we will not be able to see the soft tissue anatomy, though it is an excellent dynamic the procedure that mimics closely what the patient is going through. In addition to that, we also assess what is the damage that's been caused to the pelvic floor, which is not possible to do with fluoroscopic defecography. And as more and more MR is coming up, there are very limited expertise available, and there are very limited available centers also who can perform fluoroscopic defecography in our country. Moving on to the second commonly performed, the ultrasound, which most commonly is translabial or the transperineal ultrasound. As we all know, ultrasound has no ionizing radiation. It is very easy to perform. It has a very high negative predictive value to exclude rectocele, enteroceles, and intussusception. It has a very high positive predictive value for cystocele, and is one of the easiest and simplest modality to assess the synthetic material, especially the post-operative urethral slings.
Dr. Rupa, just 1 second.
Yeah.
Just give us some time. We've lost the connection. Just give time. Dr. Rupa, there is some internet issue. We are just connecting as soon as possible.
Sure.
Dr. Rupa,
Yeah.
you can switch on your video.
Yeah. Are we all set? Can I go ahead?
Yes, you can go.
Okay, we are in the disadvantage of translabial ultrasound. Again, as any ultrasound, it is highly operator dependent, and you need to have a high expertise in performing the translabial ultrasound and also interpreting them right. And the main disadvantage of transperineal ultrasound is imaging during the evacuation phase is not possible. And most of the extreme degrees of the herniations or the prolapse are diagnosed during this defecation phase, and this is not possible with the translabial or transperineal ultrasound for all the reasons that we know. The next, so this is how the transperineal or translabial ultrasound is performed. And these are the structures that we look at: the symphysis pubis, the bladder, the urethra, the uterus, cervix, and the vagina, and the anal canal. And we have to understand that the pelvis is seen upside down on ultrasound, and this is the correlate. So this is the pubic symphysis, the bladder, the urethra, the vagina, and the rectum, and that's the uterus. So as I had shown, this is the schematic, the line diagram, which actually borders the each compartment, the anterior, middle, and the posterior compartment. And the three-dimensional ultrasound is also possible. So we acquire a volume of on the ultrasound and tomographic images, wherein all three planes is possible to be reconstructed. So this is a coronal plane, which actually, this is the axial plane, which actually shows the MRI-like picture, which beautifully, that you can see the urethra, the vagina, which is have a head-shaped vagina, the rectum. And as I mentioned before, the puborectalis is seen as a bright structure. And this is the rectum, and the coronal images, which depicts the anal. So this is the anal canal, which depicts the anal canal and also the muscles of the external anal sphincter. The third modality is the MR defocogram, including the MRI pelvis. It has become the most promising imaging technique because it assesses all the three compartments in both anatomical and functional information as possible in non-invasive way. And it also do not have an ionizing radiation. Patient has very little minimal discomfort. And it can differentiate also different posterior compartment pathology extremely well. The disadvantages, it's expensive than the ultrasound, and it has been said that unlike the conventional defocogram, we do not image the patient in the physiological position. So the patient is made to lie supine. However, there are studies which says that you have a comparable results and agreement compared to the clinical examination and the conventional defocogram. So MR has several advantages except for the cost. And when you're performing an MR, it's very important that we need to talk to the patient about the different maneuvers, because we are not only doing a static MR, but also a dynamic MR, and hence a very good rapport with the patient to make her feel comfortable. And we have to make sure that she understands what do you mean by strain. Now you strain, now you squeeze, now you defocate. So you have to be doubly sure that she has understood what she has to perform during the dynamic MR imaging. Otherwise, this study is not going to give us a useful information, and we may totally conclude it in the opposite way. So when we perform an MR imaging of the pelvic floor on a T2, we have all the three planes acquired to know the anatomical defects and also to see if there are any associated abnormalities. And dynamic MR is also performed, which lasts for a few seconds. Each of these phases lasts just for a few seconds. And the study, though it looks like so elaborate, it gets over in 10 to 15 minutes. So in dynamic imaging, we image in the sagittal plane during rest, during strain, during squeezing, and the defecation phase. And this is how a resting MR looks like. And we have distended the rectum and the anal canal with the ultrasound jelly. And this is the three imaging planes that we take to look for the normal anatomical structures, normal pelvic support, and also to exclude other associated abnormalities. And we have a lot of lines and measurements that we do in these images. The pubococcygeal line, which actually represents the plane where the pelvic floor muscles are, and the mid pubic line, which actually represents the actual layer, corresponds to the level where the hymen is placed. And we also have the H line and the M line, which actually measures the diameter of the pelvic hiatus. So there are several measurements which is not to be discussed so much here. We can grade, we basically have for anterior and middle compartment, we have a rule of 3 where 1 to 3, 3 to 6, and more than 6 is the cutoff to call it as mild, moderate, and severe prolapse. And when we use the MPL, we have a slightly different measurements. And for rectoceles, we have a rule of 2, and so on and so forth. By and large, the hiatal measurement should be less than 6 centimeter, and the pelvic floor distance should be less than 2 centimeter in any patient to be called as normal. And we also have few more measurements where, and also we look, as I said before, the iliococcygeus condenses posteriorly to form the levator plate, and which this forms a very important landmark for us on MR to see how the levator plate is oriented, whether it's parallel to the pubococcygeal line or it has an inclination which is more than 10 degrees. And we can also look for the urethral hypermobility, how the normal urethra is oriented with respect to bladder and what happens to it in urethral hypermobility. And we also have the anorectal angle, where we measure the angle between the posterior wall of the distal rectum and the center of the anal canal. The normal measurements being between 108 and 127 degree, and we expect the normal an increase in the angle during squeezing, where she's supposed to hold without letting that out. And during the defecation phase, this angle has to straighten. So this angle has to reduce so that the feces can come out without any issue. So these are the angles that we measure during different phases of the dynamic MR defocogram. And how do we basically image? So now we have said the different modalities and what are the normal measurements, what are the normal structures that we look at. The next part of it is how do we image based on different clinical scenario. So this is the literature I was talking about, which recently got published this year. And this was a consensus statement between 3 associations, which are the Society of Abdominal Radiology and the American Urological Association and American Urogynecological Society, wherein they had set the recommendations, or what we call it as appropriateness in imaging in different clinical scenarios. And way back in 2017, the European Society also have laid guidelines and the joint recommendations for the pelvic floor working group. So the different clinical scenarios that we are going to look at is urinary dysfunction, the prolapse which can happen in anterior, middle, or posterior compartment, the defecatory dysfunction, or the last clinical scenario is how do we evaluate a post-repair or a post-op evaluation. The first one is the urinary dysfunction. So we all know there are different types of urinary incontinence: stretch, urge, and overflow incontinence, which can be, the stress can be mainly due to sphincteric type of incontinence. The urge and the overflow can be because of the detrusor thickening detrusor abnormality, which Dr. Tamil Selvi had already spoken about, and low bladder compliance. So what do we really look at when you see a case of urinary incontinence, apart from looking at a cystocele? You can look at the sphincter muscles. You can tell them whether the muscles are, there is an integrity, is there a length is sufficient, and what happens to it, to the bladder neck during the strain. And we can also look at the supporting structures, which I had shown you before, those ligaments, and is there any asymmetry in these muscles which contribute to the urinary continence, and how is the posterior fornix seen, and what is the shape of the vagina? The shape of the normal head-shaped vagina, if it is lost, can indirectly tell us that the para-vaginal support to the urethra is lost, and that is why, and that can contribute to the urinary incontinence. So in this case, you can see that the normal head-shaped orientation of the vagina is lost, and there is also an indirect sign which says that saddle sign, wherein you can see the protrusion of the posterolateral aspect of the bladder wall. So these are some indirect signs, and we also do not see these ligaments very well. I had shown you earlier how the ligaments are beautifully seen on MR, and we don't see any of them. So all these contribute to her urinary dysfunction. So when it comes to the ACR recommendation for urinary dysfunction, so what is usually appropriate is performing a fluoroscopic voiding cystourethropy to look for reflux, to look for residual urine, and see what really happens during the voiding phase. But what may also be appropriate is performing a simple ultrasound and also a MRI. So moving on to the second clinical scenario, which is the prolapse. And the prolapse can occur in all compartments. When it happens in the anterior compartment, we call it a cystocele. When it happens in the middle compartment, we see the uterine prolapse. In a post-hysterectomy, it can be a vaginal apical prolapse. And in the posterior compartment, we call it as a rectocele or a rectal prolapse or an intersusception. In the anterior compartment, when the bladder descends more than 1 centimeter, you technically call them a cystocele, though we do not treat all of them, and you know that. And it also elongates the vaginal hiatus. And when it is so significant cystocele, it causes an anterior vaginal bulge, which you can actually appreciate on a good clinical examination. Why it happens? Because there is tearing, stretching of the pubocervical fascia or the levator ani. As I said, we don't really see the pubocervical fascia, but we only indirectly appreciate that could be a damage because we have a cystocele. However, levator ani muscle damage can be very well be seen, and all the urethral ligament injuries also can be very well seen. And the urethral hypermobility is a functional disorder wherein I will show you the picture. There will be a horizontal orientation instead of a vertical orientation. So if you remember, I talked about how the urethra is oriented normally is an important anatomical landmark that we have to note down. Any deviation from that, which can happen because of the loss of urethral sphincter or distortion to the ligaments. And again, in a very gross, severe cystocele, this urethral hypermobility can be completely masked. So this is the ultrasound, the transperineal ultrasound, which shows that there is a gross cystocele, and also which is also seen on a 3D picture. So this is the level which corresponds to the PC line and anything which is beyond. So in ultrasound, it will be totally in the opposite direction, upside down, and anything which is up that is seen is a gross cystocele. And this is a patient. You can see that this is during the rest. She also has got an urethral sling, and this while performing a Valsalva maneuver, you can see that instead of the urine being held, the bladder sorts of funnels, and you can see that the urine is escaping into the urethra during Valsalva, which we do not expect. And again, this is a very gross, even during rest, you can see some amount of cystocele, and during Valsalva, you can see a gross cystocele, which is forming a bulge into the anterior vaginal wall. And this is an MRI. You can see that during the rest, the bladder is well above the pubococcygeal line. The urethra is very well vertically oriented. But during a strain or a defecatory phase, which is happening here, you can see that the prolapse is happening in all the 3 compartments. And what is important here is to look at is the horizontal orientation of the urethra, which is because of the urethral hypermobility. Normally, we expect it to have a vertical orientation in relation to the urinary bladder. Here, you can see the horizontal orientation or the clockwise rotation of the urethra. And this is another example to again shows the urethral hypermobility and the cystocele. And you can see there is an asymmetry in the vaginal wall. There is a gross thinning of the puborectalis muscle. So this damage has caused, and also possibly the pubocervical facial damage has caused, there is a asymmetric deviation of the vagina, and the normal head-shaped vagina is not seen anymore. The middle compartment, you have an uterine or an apical prolapse, where which also elongates the vaginal hiatus. Again, during the descent, the vagina, instead of having a vertical orientation, can become shortened and have a horizontal orientation. And this again can be because of the same facial and the muscle problem. In addition to the uterine prolapse and the cul-de-sac herniation, this is something which may be very difficult to assess clinically, wherein you actually can see what if the herniation is seen or not, and what is the content of the herniation, and we can very well inform the patient or prepare how we also have to suture the cul-de-sac because of these components. So there are several examples. This is the case of the transperineal ultrasound, wherein you can see the cervix is grossly beneath the level of the bladder. This is a uterine prolapse, and this is a case of a peritoneal seal, wherein you can see this is the apical prolapse, and you also, in between the vagina and the rectum, you can see a gross prolapse of the peritoneum and the small bowel loops. Again, and another case, a very thin line, but still MR can appreciate this very easily, that there is a peritoneal seal here, and again another case which is showing a gross peritoneal seal. So when it comes to the herniation or the prolapse, which is involving the middle compartment, the fluoroscopic cystocolpoproctography is usually appropriate. However, you have to remember that there is a significant radiation that is associated with it, and MR is considered as an equally good alternative, which does not have radiation and which also has got several inherent advantages of visualizing the soft tissue component, or which with this excellent soft tissue resolution. Moving on to the posterior compartment, you have a rectocele and rectal intersusception. Rectocele is the anterior rectal wall bulge into the posterior vaginal wall, and you can most common is anterior, but you can also have a posterior and a lateral rectocele, which are less common, and this happens because of damage to the rectovaginal fascia. Again, this is best seen on the defecatory phase. So that is the reason MR scores over ultrasound in these cases, because the defecatory phase, which actually shows sometimes the diagnosis only in the defecatory phase, and even if it is seen, the severity is best assessed during the defecatory phase, because that is the maximum pressure that is given to the pelvis, the transmission of the intra-abdominal pressure. So defecatory phase is the key phase wherein we look at the severity of these rectoceles, and it also differentiates the varying degrees of the rectal intersusception. The MR can help us. So this is a case wherein you can see there is an anterior wall of the rectum is slightly bulging here. So this is an anterior rectocele, and this is an ultrasound which shows the same one on, and it is slightly difficult. You need a lot of expertise to actually appreciate. It's not that we cannot see rectoceles during the training phase. We can see, but it's much easier and convincing for the clinicians, and also to show the patient and discuss them about their issues. So this is there are 3 grades of rectal prolapse, and this is the rectal intersusception, which you can very clearly see and which dictates the difference in the management. And you can also appreciate a very thin peritoneal seal. So this is the advantage of MRI. You can see that the 3 compartments is involved, and you also have a cul-de-sac herniation with only fat as a component, as a herniating component. And in addition to these prolapse, as I said, you can see all the structural abnormalities very clear. There is an asymmetry in the vagina. There is gross thinning of the puborectalis muscle on the right side, and the signal intensity is completely fibrous. This is the normal signal of the the iliococcygeus, and this is completely fibrous. This is a fibrous tract. So the same picture can also be seen on a very good 3D ultrasound in a good hands. So it's not that we cannot see on a transperineal ultrasound. We can see, but it depends on who does it and how good the images are obtained. Moving on to the third component, the defecatory dysfunction. In addition to the prolapse and the rectal intersusceptions and the rectoceles, we also have certain functional pelvic disorders, which are the descending perineal syndrome, aneurysmus, and the anal incontinence. The descending perineal syndrome can be because of the damage to the pudendal nerve, which results in complete loss of the muscular tone to the pelvic diaphragm, which leads to descent of the entire pelvic floor down the PCL, and also increases the pelvic height. So what really happens is there is not enough space coming down. There is an incomplete evacuation and constipation. More strain goes to more damage, and finally can result in incontinence. So this incontinence, which is resulting from the descending perineal syndrome, is totally different from the total anal incontinence. And even a the prolapse can result in some incontinence. So how would you really differentiate between these? MR really helps in how to differentiate. So even during the resting phase, you can see that the hiatus is wide open. It is 7.7 centimeters here. The normal dimension should be less than 6 centimeters. And you can see all the structures are already herniating down during the resting phase, which is grossly exaggerated during the defecatory phase. So there is complete loss of the tone in the pelvic musculature, which results in the prolapse even during the resting phase. And the second one is the anismus, which causes by the paradoxical contraction of the puborectalis muscle. So instead of decreasing the anorectal angle and bringing up into a straight line for the defecation to happen, that fails. And that results in incomplete emptying, or there is a very long interval between the anal canal opening and the start of the defecation. And because of the paradoxical contraction, which happens continuously, there can be hypertrophy of the puborectalis muscle. So remember, I talked about the anorectal angle, which has to decrease during the defecatory phase. So it has to come as a straight line instead of a curvature for the feces to move very smoothly outside the anal canal. But what really happens in paradoxical contraction during the patient, when the patient is attempting for defecation, is instead of the angle getting reduced, it's getting more and more. So the straightening doesn't happen, and the patient is unable to actually defecate. And this is a very typical finding seen in anismus. The last part is the anal incontinence, which can happen because of sphincter damage. Again, we can see very well whether the muscles are intact or the muscles are replaced by fatty tissues. And when there is a damage to the internal sphincter, unaware fecal leakages occur. And when there is an external sphincteric damage, the patient presents with an urge incontinence. And of course, for anal incontinence, the functional evaluation to diagnose anal incontinence, still manometry stands the gold standard. However, for the diagnosis, it is just not enough. We need to also understand what has caused the anal incontinence, where the MR comes into a picture. It can be because of the anatomical damage. It can be because of the descending perineal syndrome. It can be because of the intersusception. Those differences and the damage to the anatomical structures are well brought out in MR. So this is a case during the squeezing phase, she is not able to hold it, and she has already passed instead of holding it. And we can also see that the internal anal sphincter is completely replaced by a fatty tissue, and there is a damage to the internal sphincter in this case of anal incontinence. So what does the recommendation says? The person who presents with defecatory dysfunction, all three modalities are definitely appropriate to address. And remember, whenever we are performing a fluoroscopic cystoproctography, there is a radiation. And when a study which can perform equally good or better than what we see in fluoroscopic cystography without a radiation, why not try an ultrasound or an MR defecography in these situations? The last clinical scenario is the postoperative evaluation. In a post-surgical imaging, in case of a stress incontinence, we use the mid-urethral sling, which can be placed retropubic or transobturator. And in an organ prolapse, we can either put meshes placed either transvaginally or transabdominally. So this is an example of a retropubic urethral sling. As you can see, on a sagittal image, it's impossible for us to tell where the sling is placed, whether in the retropubic or a transobturator. However, if the coronal reconstructed image on ultrasound can tell us that this has a very acute U shape, and the transobturator will have a sort of a more straightened. It won't have an acute U shape. So that is how we differentiate how the slings are placed. And when it comes to the mesh, the sagittal plane is very much useful than the coronal reconstructed plane. And as you can see, this is the bladder urethra, and you have a urethral sling here. This echogenic line is the vagina, and the one which is seen posterior to that is what the mesh. This is how the mesh looks like for us on ultrasound. And when it comes to assessing the complications of post-repair, you can have erosions and perforations of these slings into the organs. You can have fragmentation. You can develop infection or abscess. You can have recurrence of prolapse. You can have fistula, so on. And MR really holds good in evaluating the post-operative complications because we have a wide field of view. And sometimes when the human tissue sling is used for repair, it is impossible for us to assess on ultrasound because it mimics the normal vaginal tissue or an urethral tissue, and it is not possible for us to differentiate unless we use a non-human repair structures. We won't be able to see them on ultrasound. And anything which is close to bone, the retropubic, or when the sling is extending up to the sacral promontory, it is not possible for us to see it on ultrasound. And here again, MR helps us a lot, especially in sacral colpopexy and the retropubic slings. And to assess the actual extent of infection, presence of infections and abscess, MR again holds good for us. So in the last the clinical scenario, where is the follow-up imaging after pelvic floor surgery to assess subacute and chronic complications, MR actually holds good. To assess just the integrity of the sling, maybe an ultrasound, good transperineal ultrasound by an expert will be very good. However, when we have to assess the complications and not the integrity of the sling, MR is the investigation of choice to give us the answer to you. So to conclude, imaging can detect multi-compartment level even when the patient or the clinician feels that there is only symptoms or the findings associated to one organ or compartment. Transperineal ultrasound is easily available. However, we have to remember that it is an operator-dependent technique. MRI with an MR defugogram is a reliable imaging technique and can detect both anatomic and a good functional component, provided you have explained the patient very well how to perform these dynamic maneuvers. And stress incontinence, the first clinical scenario that we talked about, avoiding cystourethropography with or without ultrasound and MR, dynamic MR imaging. When it comes to the organ prolapse, again, MR is much better because we assess not just the function, but also the anatomical damage which is causing this prolapse. When it comes to defecatory disorders, all three modalities are good, however, or equally good to address the clinical situation for diagnosis, but much more informations are definitely will be there on MR defugogram. When it comes to the fourth clinical situation, the post-surgical complications, MRI is the investigation of choice. There is no second thought when you are assessing about the complications post-surgery. MR is the investigation of choice to ask for. Thank you. These are my references.
Thank you, Dr. Rupa, for the excellent and elaborate presentation. Any questions from the audience? There are no questions posted on the chat box either. So with this, we come to the end of the session. May I request Dr. Shrikala to propose the vote of thanks?
Dr. Rupa's talk was really mesmerizing. The images. The images, and especially she has marked for us, because many times when we see those images, we may not really be able to understand. So how she has marked for us to see, I think we should go back again and then learn it well, so that we are more used to the society to help them with all these dysfunctions which we are going to tackle. And we're extremely thankful to her for such a lovely talk. Now, I don't have any questions. Any questions, madam? Okay, so then with this, Dr. Rupa, they wanted you to tell whether there are any reference books for MRI for pelvic floor dysfunction.
You can actually search good journals on the pelvic floor. Actually, there are not books I'm aware of, but there are recent literature which has come, which I showed you about the consensus statement. If you go for the ACR appropriateness in pelvic floor and European Society of Urology guidelines, they excellently tell you what you have to do for each clinical situation. The American College of Radiology appropriateness guidelines and European Society of Urology recommendation or the working group. These two are very good references for which actually addresses the clinical situation and the investigation to ask for.
Thank you, Rupa. It's my pleasant duty to propose a vote of thanks. At the outset, I would sincerely thank my mentor, Professor PM Gopinath, who has guided me to go about with the last year's SOVC, right from how to organize, how to call, how to invite, how to remind and everything. He has been wonderful. I really hope that we would be able to utilize this experience and go in a little better way. We go forward from this. So thanks a lot, Gopi sir. And next, and also the entire team who was with us, as well as the faculty, everybody whom we asked was really, they cooperated well, and the delegates, thanks to the entire team and the work which we had done in the previous year. Regarding this program, my sincere thanks to MGM for such a wonderful organization, their team, their support, and all their top brass, the CEOs who came and blessed us in this function. My sincere thanks to all of them. My sincere thanks also to my dear friend, Dr. Tamil Selvi, who as usual is an excellent orator, and her crisp talk was excellent. And also to Dr. Rupa, a wonderful topic. We all must improve on this, I think. Really thanks a lot. And sincere thank to all the team, all the delegates who came in spite of this. Still, we are not away from the corona pandemic. I hope we will improve in our numbers. And thanks and welcome to the incoming team also. And my sincere thanks not only to the MGM team, also to Mr. Balaji and Shield for being ready to sponsor our subsequent programs also. I hope with the able guidance of our new president, Dr. Jayashree Gajraj and Nirmala Jaishankar Madam, we will be able to do a good job. We promise a wonderful year ahead on behalf of the new team. We thank all of you and we solicit your full cooperation throughout. Thank you.
Thank you, ma'am. Before we move on to the high tea, I request all the dignitaries to come onto the dais for a group photo. May I request Dr. Jayashree ma'am to hand over the memento to Dr. Professor PM Gopinath, sir. To Dr. Nirmala ma'am. And to Dr. Srikala ma'am. Thank you, ma'am.